Namaskaram. I am Dr. Shiva Shankar Dalai, Chief of Neurovascular Intervention at Medicover Hospital, Visakhapatnam. Today we have a young lady who is around 46 and she has a massive subarachnoid hemorrhage. Subarachnoid hemorrhage means it is a kind of bleeding inside the brain which happens in the brain because of rupture of a vascular structure, typically because of an aneurysmal bleed. A subarachnoid hemorrhage can also happen during head injury, but we are talking about a subarachnoid hemorrhage which is spontaneous without any head injury. If you look at the CT scan here, you can see the bleeding in the subarachnoid space, in the left sylvian cistern, right sylvian cistern, anterior interhemispheric fissure, and this blood is spreading everywhere. Now, how do we understand that the patient is having a subarachnoid hemorrhage? Any patient who complains of a sudden severe headache, they complain that this is the worst headache of their life, then you suspect that the patient might be having a subarachnoid hemorrhage. Some people say it's a thunderclap headache, worst headache of their life, and the headache may be associated with neck rigidity or sudden blindness which they might recover from within few seconds or minutes, or the subarachnoid hemorrhage might be so severe that the patient might collapse and have a very bad outcome because of this subarachnoid hemorrhage. Now, what are these aneurysms in the brain? Aneurysm in the brain is a weak area over the blood vessel which has a propensity to bleed. Once an aneurysm in the brain bleeds, 30% chance that they will not be able to come to a hospital, they will die then and there. But 70% of the patient who had an aneurysmal bleed can reach the hospital, and those patients runs a risk of rebleed of this aneurysm within 21 days and the tune of 50%. Means half of the patient who reaches a hospital runs a risk of having an aneurysmal rebleed in 3 weeks time. So once an aneurysm has rebled, means bled twice, then 99% of them will lose. That's why it is like a ticking bomb in the brain. So these aneurysms must be treated as soon as possible. What are the methodology to treat brain aneurysm today? There are two ways how we can treat an aneurysm in the brain. One is by opening the skull, putting a clip which is called a clipping. The another method of treating a brain aneurysm is without opening the skull, by doing a coiling, which can be done from a single puncture in the groin or the hand. We put a catheter into the neck vessel, that's a carotid. From there we go inside the brain and we can do a coiling. Now, in this patient who has come to us with a sudden severe headache, we did an angiogram. Angiogram is a test to understand whether there is an aneurysm in the brain or not, and if there is, whether there is one aneurysm or many, what is the size of the aneurysm, what is the shape of the aneurysm, anatomy of the aneurysm, neck of the aneurysm, dome of the aneurysm, everything we can understand from an angiogram. There are three ways we do an angiogram. One is a CT angiogram through a CT scan, one is an MR angiogram through MR angiogram, one is a DSA or digital subtraction angiogram, which is done in this cath lab. Now, the DSA subtraction, digital subtraction angiogram or DSA angiogram plus 3D rotational angiogram is the gold standard to evaluate a brain aneurysm. We have evaluated the patient. We found there is an aneurysm which has bled at the PCOM on the left, and there are two blisters on the opposite wall. So it's a very tricky situation. You have one large aneurysm and two small blister aneurysm. So we are deciding to put some coils into the larger aneurysm, which is about 5 millimeter, and we want to put a flow diverter which will be placed across all these three aneurysms, the 5 millimeter aneurysm and the two blister, the twin aneurysm. All three will be flow diverted after putting some coil into the 5 millimeter aneurysm. Let's go ahead and see how we do this case. So we have a very experienced team with us today. Parvati is alongside me and Gauri. Then we have Prasad, our Chief Cath Lab Technologist. Go ahead. Then we have stylist Sinu, who is helping us with the camera work. We have Mehul from BALT, who will be with us. in this case today, and we have Akhila and team from the neuroanesthesia side. We have accessed the left carotid artery, lateral please. So this is the lead protection, table pitch. Sometime a brain AVM can also give rise to subarachnoid hemorrhage. Sometime a dural fistula can also give rise to subarachnoid hemorrhage. But most common cause for a subarachnoid hemorrhage in the brain, which is not related to a trauma, that is a traumatic subarachnoid hemorrhage, most common cause is a ruptured intracranial aneurysm. Table pitch, mag, table down a bit, right. Brain dicospin given, heparin given,
Sir?
heparin.
Heparin given, sir.
So we can see this aneurysm, and in the 3D we can see the blisters. Can we see the 3D here? Yeah. Correct. Can you just show a rotation here? We can see this aneurysm over here, which has blade, and can you rotate it, the image? Press up. So this is the aneurysm, which is about 5 millimeter, and then on the opposite wall we have two blisters. Keep showing me. Keep going ahead, Prasad. Mic on. Keep going ahead. Yeah, keep going ahead. Yeah, keep moving. Keep moving. You can see the blisters. Keep moving. Keep moving. Keep moving. Keep moving. Keep moving. You can see. Come on. Yeah, yeah. So you see these two blisters. They could be very, very dangerous, and they can bleed and they can kill a patient. So it needs to be treated as well. So we will put some coils into the larger sac, and then we will put a flow diverter across all the three aneurysms. Please come back. Navion. Navion 6 French 072. So these are basically the coil detachment system. One is from Medtronic, one is from Bert, one is from Stryker, one is from the Terimo microvention. Can I have the screen closer to me, Prasad? And roadmap on that last run. Out. So we are slowly taking the Navion across, and All right, so we are very well placed here.
Limited please.
Thank you. So can I get this one? Beta? Phenom 21. Nimodipine is running. Phenom 21 with a synchro 14. Yeah. Yeah, okay. Paraji,
Sir.
I need a next Y connector one more.
Ready sir.
Blot the cable beta. Chal. Can you give me another Y connector? Can you give me a syringe and the needle which can do a little bit of flushing? Paraji?
Sir, ready.
There. Do you have the Phenom 21 ready?
Ready, sir.
So we have the Neuron Max here, we have the 6 French Navion going there, and now we will take the Phenom 21 with the Traxxas 14, 12, 14, 150, 200 centimeter. Can I see the Traxxas? What Traxxas you have given? Okay. Go ahead with the wire, ma. So given a gentle J shape to the Traxxas, we'll try to go through David Beach. Back, ma. Plus is attached. Excellent. Can I have the torque on there? So we have gone into the desired location on the middle cerebral artery. There. Can I have this one? Phenom 17. Phenom 17. Sorry? Huh? So today Prasad is with microvention looks like, huh? Huh? I love this. I love the headway. Headway 17? Yeah. Do it. So Parati, what is there for lunch today? Kakarkai. Epicranial. So neuron max we are used, which is from Penumbra. Then we have used the Navion, which is from Medtronic, and then we have used the Phenom, which is from Medtronic. Then we have used the Traxxas, which is from Microvention. Then we are using a Headway, which is from Microvention. Patient fine? So beautiful. Now we will approach, go to the aneurysm. Max Mag. Max Mag roadmap. Very nice. So, Headway 17 and the Traxxas. Headway 17 is a very good catheter. You had Headway 21 also? Huh? Headway 21 leda. That's also a good one. Can I have the screen closer to me? Going? Slow. Put one more flush. So we are trying to approach the aneurysm. So one has to be very, very gentle here, especially once it is a blood aneurysm, extra causes. Can I have a torquer? Leave it to the end. Torquer first. Then we can put the flush in. Just good. So we are pushing inside the aneurysm. You can see my catheter slowly getting there. That's how it is. Out. Now you put the flush on me. Out. Wire out. Zabardast. Give me the needle with the syringe. So we have taken our microcatheter inside this aneurysm. Another microcatheter is placed across. So once we just put couple of coils, we will start putting the flow diverters across these three aneurysms. What do you give me in 4? What do you have in target new? Give me a target 4 coil. Striker. Okay, we can try this Optima 417. So we are trying with a 417 Optima. Maybe just 1 or 2 coils, not much, and then we can. 417 will be actually a good size. Yeah, please. So this is a detachable platinum coil, 4 millimeter in the diameter, 17 centimeter is the length. Can I have the screen closer to me? Beautiful, beautiful. So you can see the microcatheter almost close to the wall, and once we just go close, we can simply pull our microcatheter a little bit back so that the coil doesn't exit and hit a wall right away. You see it? We just withdrew it a little bit. See this. See, that's not a good thing. Can I have the lights off? So I'm trying to reposition my microcatheter a little bit. So I'm just so this is how we have to reposition, play it with a little bit. So initially it looked like you were completely out of the aneurysm, but once you understand what you are doing, you can reposition and recoil it a little bit to have the whole coil mass within the aneurysm, within the. You see this. So if you just start looking at the initial part of the coiling, it looked like we were out of target, but you have 21 microcatheter in the neck, which is just giving some kind of support, and you just play it with a little bit and then try to reposition the coil into the aneurysm, and this is how it looks so beautiful. You can see the fluoro image up there, which is giving you a clear guidance. Can you give me RAO 32 cranial 30? RAO 32 cranial 30. RAO 32 cranial 30. You see this? The coil is absolutely sitting beautifully inside this aneurysm. Now I feel good because the patient is loaded on, and now we have the coil as a protection. Table please. Perfect. So this look beautiful, so I don't have to do much to the aneurysm. With the flow diverter it will look beautiful. We don't have to really pack and do anything about it. This is absolutely good. Can we detach? Lights on. So for detachment we have a detachment system which we have to engage to the distal end of the coil. Once it is engaged, you see this green light, and then you press and the beep which tells you that this is detached. And very carefully you should take the pusher out, and the coil is detached and the pusher is out. Now it's time for us to just go ahead and finish the flow diverter, because as I said, no need to pack it further. It looks already great. Go back to lateral, beta. So that will be our working projection for deploying the flow diverter. Flow diverters are the closed mesh stents which will be deployed in the lumen on which these aneurysms are there, and they will divert the flow into the normal circulation away from the aneurysm, which will give us a fantastic occlusion of these aneurysms over the time. So see, we are quite satisfied with this. Stop. So this is looking good. I'm quite happy. I will come out with this microcatheter. And sometimes if the aneurysm is very wide neck and dependent, then you can actually gel it. You can gel your microcatheter and then you can do coiling after the. So you can put inside the aneurysm, you can put your microcatheter, and then you can put your flow diverter, then you start coiling. But here I was sure that the neck is good enough for me, so that I can just go ahead and coil it without a kind of assistance with a balloon or a stent or a flow diverter. So I just coiled it first, then we will put a flow diverter here. So we'll start deploying the flow diverter from the epicranial view, and as we move we will come back to this lateral view as we deploy it across the aneurysm. Epicran. So far so good. Let us see what we have achieved till now before we go ahead with the flow diverter. Table. All right. Super happy. I'm looking at a beautiful picture here. So we will start deploying the flow diverter from here as we come down. So the aneurysm is looking pretty good. Coil mass is well within the aneurysm and is well protected. Can I have the flow diverter, which we will be selecting today is about 4.25 into 25. That means the diameter of the flow diverter will be 4.25 millimeter and the length will be 25 millimeter. 4.25 into 25. So this is the technical specification. This is a silk vista and we are taking a 4.25 into 25, and this can be squeezed into 3.5 where the length will be 37, and if it is relaxed into a 4.5 vessel, the length will be around 80. The super mechanism by Paro Padko. So you like Karela or just by compulsion you will have? Yes. Telugulo cheppandi re. Yes. What is yes? You getting the fluid?
Yes, sir. First drop is coming. Only one.
Good.
Two more, sir.
I love the way you look tonight.
Second.
హ్యాపీ ఎందుకు లేదు మా ఏమైంది? ఓకే.
Yes.
Let's do something amazing. Louder. Cause I never touched somebody like that. Touch your body. Now I never wanna let your body go. Let's make a night. Go lateral, beta. Okay, wait. Leave it. We'll go and start deploying from this and then go to lateral to finish off. Sorry? Distal deployment lateral. Proximal in epic run. So it's very important for us to see how the flow diverter opens, because that is the trickiest part of it. It's not like a regular laser cut stent which will have a great radial strength which just opens off on its own, but you really have to play with it and create a little bit of push and pull, a little bit of magic to have it open, and once you can open it well, then that's the job done. Go ahead. Smooth and easy. इसका प्रेशर देख. Okay था? Paro ji? All fine? Good. Paro is finishing the case so that she can have Karela going out. So without those two blisters on the opposite wall, we could have done a balloon assisted coiling at this stage. And the subarachnoid hemorrhage we see is not gross, so it gives us the leverage to try and do that. And is 9 days post bleed. 9 days post bleed is a great idea, because 4 to 11 days are the chances of this vasospasm, and once the patient is conscious, doesn't have a problem till the 9th day, it's very unlikely that you will have vasospasm. And if you just look at the angio right now, it looks absolutely good without any kind of significant vasospasm, which also gives us a very it's a different level of confidence to do this antiplatelet. So it's a good idea to keep the things distal, and then you can pull back slowly so that the lag on the catheter is being taken care of, and the chance that you will have a slippage of your device is less. So this is absolutely where we want it. We might go little distal here, little. This will be a good choice. Meanwhile, what I'll do is I will push my navium up for support, and this will be a good position for me to deploy. So this is the trick here. You have to be very consistent and have patience, and don't really worry about things. Rather than, you see this beautiful cigar like opening here just at the supraclenoid ICA, which is what is the idea. Beautiful opening here, you can see. And never take anything as an easy or a simple case. Anywhere you are trying to do a flow diverter, you should be absolutely careful about, because anything can happen. What looks so simple to you may not be so simple. So beautiful. Now lateral, please. Roadmap out. Where is the bro? Lateral. So this will give us a better visibility. Excellent. See this opening very well. Now you see the proximal end opening well. That is how you should deploy a flow diverter, not like a blind person and hoping things will happen. No, they don't happen. If you don't do it well, that will not happen. So that's how you have to do it. As you see, it's very well opened end to end, and then you can just take it a little bit inside for a little bit of massaging and record the loop. You see this? So beautifully deployed flow diverter. Table, please. Down. Down. Ekkada undi Baba? Prasad is today movie, eh? Okay. So now let me just show you. So you can see this well. Ma, ఇది ఫ్లోరో చూపించండి మా. Last one fluoro. Yeah, fluoro. So you can see this coil mask inside the aneurysm, and you can see the flow diverter distally and across and proximally. It is a short, sweet, well opened flow diverter. So the last one, huh? ఫ్లోరో దిఖా ఇస్మా ఫ్లోరో చేయండి దానికి ఫ్లోరో చేయండి యా స్టాప్ మ్యాగ్ max mag no go to that run and show me yeah exactly beautiful. Now you see this is the coil mass inside the aneurysm. This is the distal end of the flow diverter which is well opened across the length, and then this is the proximal end, and this is how it is. So this is how it has to be done. So we have done a flow diverter and coiling for a ruptured intracranial aneurysm with 2 blisters across the opposite wall. See this beautiful epicranial. Okay, cover the head. Let's see the intracranial circulation. Table, please. So this is the angiogram to tell us how we have performed. Absolutely good intracranial circulation. Epicranial. Yeah. So you see, so this is a very good intracranial circulation. There is no infarct, no bleed, no occlusion of any vessel or anything. We have a coiled aneurysm which is looking perfectly fine. We have flow diverter which is looking great and opened very well. So this is a procedure that was done for a ruptured intracranial aneurysm which is 9 days old, and there's no vasospasm. There are 2 blisters on the opposite. We have done a coiling and the flow diverter successfully, and this is a fantastic thing that we have done by grace of Almighty. And thank you all for watching this procedure, and we will see you soon for the next one. Thank you so much from Visakhapatnam. Have a great